Hello, everyone. We will wait for just a little bit of time so that everybody gets into the webinar, and then we will start. So, good afternoon, everyone, and welcome to this European Society of Contraception and Reproductive Health webinar about empowering choices, one decision at a time. And this is to honor World Contraception Day, which is today. This webinar is sponsored by Bayer. We are extremely grateful for their support, but they have had no influence on the content of the webinar. My name is Helena Kallner. I'm the former president of this society. I work as a senior consultant in obstetrics and gynecology at Danderyd Hospital, and I'm also an associate professor and researcher at Karolinska Institutet. I'm so pleased to have you here with us today and to celebrate this day, because contraception has indeed changed the trajectory of our world, and especially for women worldwide. And we must honor how important contraception is to the freedom and reproductive rights for women and men all over the world. And contraception holds the future of all our societies and has a huge role to play in the sustainability for our world. And with that, I would like to give the word to my co-host and co-chair, Philipp Quaas.
Thank you, Helena. Thank you for those wonderful words. Happy World Contraception Day to everyone, and thanks for joining. My name is Philipp Quaas, and I am working in Basel in Switzerland. I'm a senior consultant for OBGYN, focusing on REI, reproductive endocrinology and infertility, and focusing on contraception. And I'm very happy to co-chair this wonderful webinar with Helena. We have a wonderful program planned. We have three wonderful speakers. Teresa Bombas from Portugal, who is gonna speak about contraceptive choices for young people. Helena Kopp Kallner from Sweden, who is speaking about contraception after pregnancy, and Johannes Bitzer from Switzerland, who's gonna speak about contraception in the perimenopause. So we have a very interesting program planned for you, and we just want to talk about our great society quickly, the European Society of Contraception and Reproductive Health. You should become a member. The membership fee per year is 70 euros or 130 euros per 2 years. You can easily apply using this link shown here, and you have many benefits, access to the official journal, free access to webinars, and reduced congress and event registration fees. So a lot of benefits, so please join this great society. The aims or the mission of this society is shown here. It is a leading professional society working collaboratively in Europe and beyond to champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decisions in choosing and using contraception. So the mission is very important, and if you are already a member of the society, you can access doc matter and ask questions and submit comments about this webinar. You're very much invited. Some practicalities about this webinar. You are very welcome to ask questions. For that, you please use and activate the Q&A button in Zoom and then type your question, and we will try to answer this question after the lectures, after the presentations in the end. And you can upvote each other's questions if you click on the thumbs up sign, so we can prioritize the questions. and a selection of questions will be addressed after all lectures if we have the time, and unanswered questions will be addressed and added to the ESC website. And with that, I give the word back to my dear colleague and co-host, Helena Kopp Kallner.
Thank you very much, Philipp. So it's my great honor to introduce our first speaker, who is our current president of our society, Teresa Bombas from Portugal. She works as an OBGYN, and well, you have been engaged in this society for a very long time, just like I have, and it's my pleasure to give the word to you, Teresa.
Thank you, Helena. Philipp, I think you have to close your slides, otherwise I cannot show mine. Are you seeing my slides now?
Not yet.
You have to close
black.
yours.
It says that you started, but it's all black, Teresa.
Yes. Something wrong. We try this. So maybe we do this. So maybe you
Ria, can you share the slides, please?
Okay, maybe you can move, Helena, and I will try to check what is going on. Okay, I think I have this now. You are seeing my slides now?
Yes.
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 Okay, perfect. Sometimes it happens. We try a lot, but it happened. So thank you for everyone to your introduction. Welcome everyone in this in this World Contraception Day. It's my duty to talk about contraceptive choices for young people. I'm a senior consultant obstetrician. I work in Portugal. I don't have disclosures for this lecture. And why is important to talk about contraception for young people? Because nowadays, 1 in 6 people alive are a teenager today. So why is important contraception? Because when a girl becomes pregnant, her present, her future will change radically. And normally it's not for the better, but it's sometimes the school and all the life after the pregnancy will be modified and with some complications. So what we have in New World today, the problem of adolescent pregnancy is more in low and middle income countries. And we estimate that we have per year 12 million of adolescent births. In the other hand, we are talking about births, but in the other hand, we have abortion in the adolescents. So the majority of this abortion will happen in countries where abortion are not safe and not legal. So there's a problem that we can prevent if the access to contraception is good. And in fact, there's a huge evolution, and what we have 60 years ago is not what we have today. The majority of the countries in the world, the number of the adolescents who become mothers decline. This is especially important in countries like European countries. But if you look other countries in the world, like Latin America and Caribbean and Africa country, is not is not so true. And last weekend we have a nice webinar with our colleagues from Latin American countries. It was a webinar organized by Pan American Health Organization. It was sponsored by ESC, and we discussed a lot the adolescent pregnancy and contraception for adolescents. So we are very comfortable here in a European country, comparing it with the rest of the world. In fact, when we look for the rate of pregnancy, I show you before in the last slide, the rate of adolescent pregnancy are low. And in some countries, the rate of abortion between adolescents are high, especially in countries like UK and France. In the majority of the other countries, the rate are quite low. I'm seeing here the rate in Portugal is quite low. In Spain, it's a little higher than in Portugal, but in the majority of the countries, the rate of abortion between adolescents are lower. So when or how we can prevent the unplanned pregnancy during adolescence? We know that are factors that contribute to adolescent pregnancy. Low access to sexual education is one of them, low access to contraception. And in some areas of the world, girls are under pressure to marry and bear children. Girls choose to become pregnant because they have limited education and there's no future plans. And other aspect is related with child abuse. And when we look at the sexual education and we focus on European countries, the majority of European countries have a plan of policies regarding sexual education. And if we look, the countries where the sexual education is not so frequent or is not a project or a plan are the same countries where a contraception or sexual health are not accessible. We know well this contraception map, and we know that the countries are ranking in different different position. And but when we focus on access to contraception between adolescents, we see that there's special coverage for young people in the majority of European countries, but in some countries we have barriers in access to contraception. One of them are the parental consent to access to contraception. That's true in some European countries. So we can think about what are the unmet needs for family planning between adolescents? And as I say before, and what are the tendencies for that? And there's a long way that we have done. All of us contribute to this access to modern access to contraception between all the population, but in focus between adolescents. And in fact, the numbers of women or girls that have a unmet need for contraception decrease in the majority of the regions of the world, especially in European countries. But we have some problems in African countries where the number of adolescent pregnancy and the birth from adolescent are higher. And this is related with mortality. So there's a huge work that we have to do in this region. So let's come back for our topic today. What adolescents expect and need from a contraceptive method, or what adolescents expect from us as provider. In fact, the adolescents need efficacy. When you look to all methods of contraception that we have in a European country, we have these long-acting methods. They suit very well to adolescents, are easy to use, are very effective, and they are long-acting methods. But of course, we cannot forget this is a choice, and this is a choice, and it's not a question. And like other women, the adolescent woman could have their choice. And with special focus in this group, we cannot forget that it's important to promote double Dutch. It means use a very effective method and use a condom to protect of sexual transmitted disease. And regarding the use of long-acting methods, the ACOG, the American College, produced a paper in 2018 about the use of long-acting methods between adolescents. And the recommendation there are that the long-acting methods are safe. The complications are not different from the other women, the complication that we have with long-acting methods, including with intrauterine system, because they have some misconception between adolescents and between providers regarding the use of intrauterine devices in this group. So today we can say that it is completely safe and to use intrauterine device between adolescents. Of course, we should promote, as I said before, the double Dutch and use a condom at the same time that we use intrauterine or an implant. And it's important to have this opportunity during this consultation to screening of chlamydia. And why is important use of long-acting methods? It's important because they are very effective. The duration of use are longer, and the rate of the continuation is higher between the implant user and intrauterine device users. There are some studies from years ago from United States, and we know that between the adult woman, the rate of discontinuation of pill is near 80%, and between adolescents, the rate of discontinuation of daily use method like pill, it's a double, like 20%. So between adolescents will be comfortable if they want to use a long-acting method, and it will be safe to use a long-acting method. But what is important nowadays is that all the information that we have regarding scientific studies is that age itself is not a barrier to use any method. So healthy adolescents could use any kind of method, the method of their choice and the method that is best for them. Of course, if we think about safety, we think about safety for older women and with the focus for adolescents. But we know that between adolescents, the VTA risks are very low. And the VTA risk is when we use between the user of combined hormonal contraception is in special waiting estradiol, the rate it's increased. But we have to check well how we see these numbers, because the number of the women that will have a VTA during the use of combined hormonal contraception are 3 to 4 per 10,000. The number of the women that will have unplanned, that will not have unplanned pregnancy and will protect not only for pregnancy, but from the other therapeutic benefits of contraception are very high. So in this special population where the baseline for VTA risk is lower, the use of combined hormonal contraception, if they are healthy, is completely safe. And it's important to say, like in the other population, we only need a medical story. We don't need to do a screening from thrombophilia in this population. And in fact, adolescents are protected from the age from VTE. And we know that VTE, the risk of VTE increase with age and increase with body mass index. But when we look to the adolescents, we say even if they are obese, the risk of VTE is lower. So this is the decision between use combined method if they want, and the body max index is always a balance between the risk and the benefits. And in fact, when we look to the medical eligibility to criteria of use of contraception, all the combined methods, all are oral, patch, and ring, are safe in adolescents, even if they are obese. If the only risk factor for VTE will be obesity, so we have to counseling them well, and it's a choose and the balance between risk and benefits. When we think about young people that are smoker, and this smoking is very frequent between adolescents, we saw that when we look for older women that are smokers, if they are heavy smokers, they are not eligible for combined oral contraception. But if they are young, they are really protected by the age. Of course, it's an opportunity for counseling about the negative effects of smoking. But if they are young, it's always, like I said before, a balance between risk and benefits. And young people, even if they are a heavy smoker, they are eligible for all contraceptive methods, including combined hormonal contraception. And another worry that we have is about the use of hormonal contraception in very young people that are growing up, and what about the risk of osteoporosis? And what about the bone mineral density? We know that all the methods decrease the level of bone mineral density, and this is for all methods, but it's especially important for the user of Depo-Provera. But when we look for the adolescent population, contrary that we see in perimenopause population, Johannes will talk about it. The young population are able to use Depo-Provera because they have time to recover the bone density, mineral density, after stop the method. So if you want, or if the adolescent want to use Depo-Provera during this phase of life, they are eligible for that, because after they stop the method, the bone mineral density will have time to recover. And this is especially important because there's the Depo-Provera are very used in number different countries, in special in Africa and Latin America and Caribbean. And there are a lot of young people using these, and there was some studies regarding bone mineral density, but now we know that it's completely safe to use this method during this stage of life. And we have already talked about intrauterine risk when I discussed the efficacy of the methods. There were some concerns about the risk of pelvic inflammatory disease during the use of intrauterine methods. We know that the risks are related with sexual behavior and not related with the presence of intrauterine device, and is not different from young people, from older women. So it's safe to use intrauterine device during the adolescence, and it's important to do the chlamydia screening during this time and during the insertion. And there are some countries like mine where we have a program for screening until 25 years old, all the young people from chlamydia, and this is an opportunity for do it. So another concern is about the use of hormonal contraception and moods. We have population studies, in special two studies, one from Lidgard in 2016 and another one from UK that was published in 2022, that reveal an increased risk of moods, of impacting moods and depression, especially between adolescents. This was huge studies, populational studies, and in fact bring some fear about the use of hormonal contraception in this population. But the other studies that we have in a scientific that we have published reveal that it's safe to use hormonal contraception in a global population, including adolescents, and in a population with some risk factors, past depression, we have to be careful in this population, so we can use hormonal contraception, explain the risk factors to the users, leave an open after they start the method, 2 or 3 months. We have to see the adolescents again, check about the mood symptoms or the mood impact, and give priority to formulation with anti-androgenic progestins. So we talk about efficacy, we talk about safety, but we have to talk about quality of life. This is what they need, and this is what they expect. And we know that hormonal methods could improve the heavy menstrual bleeding, dysmenorrhea, acne, and other androgenic symptoms and signs, and premenstrual symptoms. So the hormonal contraception could have an impact in quality of life and in self-image of the adolescent, what is quite important. And when we look, let's come again to long-acting methods. And when we look to the long-acting methods, we can have this efficacy, safety, and non-contraceptive benefits. So we can have improvement of dysmenorrhea, and we can have improvement of heavy menstrual bleeding. And this is special true for implants, and this is special true for intrauterine device with levonorgestrel with 52 micrograms. And other way of optimize the use of hormonal contraception is to modify the typical regime. So we have normally a typical regime that is 21 stop 7 or 21 plus 4 pills of placebo, but we can do it in a continuous regime that is safe and it's easier to use. And we know that the majority of women that get pregnant during the use of a pill or a user-dependent method is because they forget to return the method. So if we teach about the safety and how to use a continuous regime, it's a way of improve the use and decrease the level of unplanned pregnancy. And this continuous regime increase the compliance, of course, decrease the dysmenorrhea, the heavy menstrual bleeding, and its special importance to adolescent or to women with some medical conditions that can be severe during perimenstrual and menstrual phase. And just a final word about emergency contraception. Don't forget to talk with adolescents about emergency contraception, in special if they are using a user-dependent methods. So we can promote emergency contraception. In the majority of countries they can have access without medical prescription, and we must teach them and promote the use of a most effective oral method that is ulipristal acetate, or we can offer in this time or need for emergency contraception, we can discuss the opportunity to use a long-acting method that is an intrauterine copper device. So age is not a barrier. This is my last slide. Age is not a barrier. Healthy adolescents are eligible for all methods of contraception. We must use this opportunity to counseling on contraception to promote safe sex and to promote use of condom associate with a very effective method to prevent sexual transmitted disease. And don't forget, this contraception is a choice, is not a question. Even we think this matter, long-acting matter is much better, but it's a choice for adolescent, and give a backup information about use of emergency contraception. Thank you.
Teresa, thank you for this excellent presentation regarding this really important topic. And I'm sure that we will have some questions in the end. I would now like to introduce Helena Kopp Kallner, who doesn't need much introduction. She's a senior lecturer and associate professor at Karolinska Institutet in Sweden. She's a senior consultant in OBGYN at Danderyd Hospital. She's very active in research, and she's the former president of our great society. I give the word to you, Helena.
Thank you so much, Philipp. And it's my great honor to present on contraception after pregnancy. And I do hope my voice will bear with me. I've had a terrible cold, but I have a cup of tea next to me. So if my voice completely breaks down, I will be having a little bit of tea, and all of you can just get up and stretch for a minute or two. But I hope it will work for me. So this is my declaration of interest. And of course, I also do this as a sponsored webinar by Bayer. And when we discuss contraception after pregnancy, the most important question is really, do you want to become pregnant again? And if the answer to that question is, yes, I do, then the next questions should be, when would you like to become pregnant again? Because all women who come to us after a pregnancy don't want to become pregnant again. Some do, but many don't. It's also really, really important to remember that pregnancy is not only birth and abortion. I think we often talk like either you choose to keep a baby and then it will come a birth, or you choose to terminate and then you do an abortion. But that is not the case. We have other outcomes of pregnancies as well. And those pregnancies are ectopic pregnancy and miscarriage. And all of these kinds of pregnancies can be either unplanned or planned. And unplanned pregnancies can still be wanted or unwanted. And planned pregnancies can become unwanted, such as is the case with, for example, fetal malformations. We know very little actually about exactly what proportion of pregnancies end in ectopic pregnancies and miscarriage, and it's very difficult to know. We know that medical abortion does not affect ectopic pregnancies, so reasonably we know a little bit about ectopic pregnancies. But miscarriages, not all women seek care for miscarriage, so it's very difficult to know. Also, we know that when we do medical abortion already in week like 4 or 5, very early medical abortion, a lot of these pregnancies would probably have resulted in a miscarriage. We did a study just to look at this, like how many unplanned pregnancies actually end up in the emergency room. So this was from our hospital, and it turned out that it is about the same as the abortion rate in Sweden. We have about 40,000 abortions every year in Sweden and about 110,000 births. And here, out of these 180 pregnancies, where we had them fill in the London measure of unplanned pregnancies, around 37% were actually unintended. We also looked at use of a contraceptive after an ectopic pregnancy, and I know this is a busy slide, but I will take you through it. And if we look up here, these are the women who actually had a child wish and ended up having an ectopic pregnancy, and of course they are not going to use contraception afterwards. Although you can see that a small proportion of women actually decided after this experience that they did not want to have another pregnancy, and so they started using contraception. But that's a very small proportion, right? But here you can see all of these women here, they use contraception. And what we could see after this, having an ectopic pregnancy, the proportion of women not using any contraception actually rose. So women who were in fact using an effective contraception that prevents ectopic pregnancies discontinued because they felt it had failed. And this is, of course, very counterproductive. What you want is to have women who do not have a child wish to receive an even more effective contraception, but that was not the case. And I think we can do a lot better here to think about the fact that also ectopic pregnancies can be unwanted and really do good contraceptive counseling for these women. So what contraceptive can we recommend after an ectopic pregnancy? Well, it's important to remember that any method is protective, but the most effective method is probably the implant. And the reason that the implant is the most effective one is, of course, that it inhibits ovulation and that it is a long-acting reversible contraceptive so that it is user independent. We should also, of course, inform all these women of the risk of a new ectopic pregnancy. So just to leave miscarriage and ectopic pregnancy, they are common and they also occur in unplanned and unwanted pregnancy. And there's a lack of research on contraceptive need and use after miscarriage and after ectopic pregnancy. And there's also a lack of research on contraceptive counseling after miscarriage and ectopic pregnancy. So if any of you now get an idea for a study, call me. So what about contraception after induced abortion? Well, Teresa just spoke a lot about the evidence of LARCs. These are the results of the CHOICE study, which was really a pivotal study, I think, that made us realize how superior long-acting reversible contraception is in the prevention of unwanted pregnancy. And the CHOICE study actually resulted in a lowering of abortion rates in the area where the intervention took place. And that was in St. Louis City and county resident. And you can see here that after the study, in the year 2009 and 2010, abortion rates were really lowered, or abortion numbers. So the study, just by including these slightly above 9,000 individuals, managed to lower abortion numbers. Teresa also spoke a little bit about this, but I would like to say that long-acting reversible contraception have a much higher continuation rate. And this was very obvious within the CHOICE study. So if you look to the left, you can see where it says 1.0 up here. That is where 100% are using LARCs. And then you see here, every little downward turn here is a person who quits. And you can see that there's a huge difference then compared to the short-acting methods. Many more quit those. So what evidence do we now have for contraception after abortion? Well, this is a Cochrane study. It's rather old now. Well, basically nothing much more is happening perhaps. But in this review, they only reviewed surgical intervention after abortion and miscarriage. And it showed them that moderate quality evidence shows that insertion of an IUD immediately after abortion is safe and practical. Expulsion rates are a bit higher, but still there's more use if you insert it immediately, and it is safe. But now, in most settings in Europe, medical abortion, I'm sorry about the spelling mistake, medical abortion is on the rise and is perhaps much more common than surgical abortion. And how then do we provide immediate access to the most effective contraception in medical abortion? Or is this just the downside with medical abortion that we have to accept, that we can't provide immediately? Well, there are two large randomized trials where we studied the use of implants in medical abortion. And what we saw, this is a study from the US and Mexico, where it was performed. It's a huge randomized controlled trial on the immediate insertion of implants in medical abortion. And we also did a study in Sweden. It's about, like, they are basically the same, these two studies. and we could show that we had a reduction in repeat unwanted pregnancy. And what we did in these studies was that we inserted the implant at the time of mifepristone intake. So women had the implant inserted really before the abortion took place, and it works fine. There are no interactions, the efficacy is the same, and it should be done. So the conclusion is that immediate insertion of implants is safe, acceptable, and does not lower efficacy. It's supported by several observational studies and these 2 large randomized control studies. And this is really a grade A evidence. So if you have a woman coming for abortion and you don't insert the implant at the time of mifepristone, you are not providing the highest standard of care. So what about IUD placement? Have some tea? Here we also performed a study where we inserted IUDs within 48 hours of medical abortion after we judged that the abortion was complete. And that was a clinical diagnosis. And in this study, what we could see was that women came more often for the immediate placement visit. We could see that expulsion rates were not significantly different, but they were a little bit higher in the immediate group. But foremost, women were more satisfied with the time of placement if they were allocated to the immediate group. Women also had less pain if the IUD was inserted immediately. So here you can see the intervention group, and you can see they had a little bit more pain, right? Because it was sooner after the abortion, but then they had less pain. What about later abortions after week 9? Well, this is a study from Finland, and he also saw that it was safe to insert the IUDs, but expulsion rates were a little bit higher. And you can see here that the second trimester at first year, the expulsion rate was 20%, and in the late first trimester group, it was 32.6%. So that's quite high. It is a huge difference from what we saw here, right? With a 9% expulsion rate. This is another study where they performed insertion of the Kopp intrauterine device. They also had quite high expulsion rate, 32% if you also added those removed. We performed a study also randomized comparing 48 hours to 46 weeks, or 2 to 4 weeks, I mean. And we couldn't see that it was more effective to insert it immediately because so many of the IUDs were expelled. So actually, it was better to wait with the insertion because then more women kept their IUD. In this study, we did not provide replacement IUDs. But if you want to insert immediately after second trimester, I think it's very important that you provide women with a replacement IUD so that they can come and have a new one inserted if the first one is expelled. Also, for a second trimester abortion, it wasn't advantageous to insert it immediately. Actually, women had more pain if you inserted it immediately than if you had delay insertion. Now, these are the WHO guidelines. They say that IUDs may be inserted immediately after any abortion has been determined to be successful. They say that the risk of expulsion is slightly higher. Now, I would say that it's considerably higher. And the problem is that maybe we shouldn't do this in a routine setting where it's easy to get women back. But if you feel this is your only chance, you should insert it. And this is, of course, because even if you have 25 to 35% expulsion rate, that still means that the vast majority of IUDs will stay in, right? So if you have a woman where you're uncertain, take your chance. If you feel this woman will return, perhaps it's better to wait, at least if you can't provide a replacement IUD. So we're moving along in the pregnancies from like 9 weeks to 12 weeks to past second trimester. So what about postpartum contraception? Well, first of all, is there really a need for us to engage much more in postpartum contraception? Yes, there is. This is a study that we performed in Sweden where we concluded that about 2.5% of women who have given birth have an abortion within 1 to 2 years. And as you probably know, a lot of women who get pregnant within even a year, if they have their first child, they choose to keep the second pregnancy, right? But here, these are women who have actually chosen to have an abortion. That's 2.5%. So the unplanned pregnancy rate is obviously much, much higher. And this was a rather big study, as you can see. We had more than 12,000 individuals that we looked at from the beginning and included slightly above 11,000 women in the study. Well, is there a downside with waiting with insertion after postpartum? Like I said, that there might be in second trimester abortion. Well, we know that the risk of perforation in breastfeeding women is higher. This study showed that it was about 6 to 10 times higher among breastfeeding versus non-breastfeeding women. And in most guidelines, we say that it should be an experienced inserter who places the IUD in women who are breastfeeding. Also because they have a different kind of perception of pain. So they might not indicate when there is a perforation. So just remember this. And here then, could it just be advantageous then to put in the IUD immediately after childbirth? When it comes to postpartum IUD insertion, there are a lot of different definitions floating around, makes it a bit difficult. But immediate insertion is often defined as post-placental insertion, like within 10 or 30 minutes within placental expulsion, you're supposed to insert it to be called immediate. And then you have a window that is called sort of early insertion, and that is often defined as within 48 or 72 hours. And it has been shown that both post-placental and early insertion after birth is safe for both mother and child. And of course, it is associated with other advantages for the woman, such as often if you insert it immediately, post-placentally, or within 48 hours, it's completely painless. So the woman she's like, well, tell me when you start. And you're like, well, I'm finished. That is at least my experience when I inserted a lot of IUDs postpartum in the study that we performed. And of course, because the uterus is thick, the uterine wall is thick, the fundus is thick, the risk of perforation is very low. No study has been able to show an increased risk of an infection, might even be a lower risk of infection if you insert it immediately. And women have a very high acceptance of the procedure, but there is a high risk of expulsion. However, there's a huge variation between studies, and this is often affected by the rate of follow-up. All studies that have a high rate of follow-up with insertion postpartum have a high expulsion rate, I might add. And I think our study had one of the highest, it was 44%. And here, if you're interested, I've listed some studies that you can have a look at. You can just take out your phone and take a picture of this slide if you want to. So what about placement then of an IUD at a cesarean section? Well, there have been quite a few studies showing that it is effective and safe, whereas I think that in high resource setting, it hasn't really been implemented. But this is a very nice study from Scotland, where routine provision of intrauterine contraception, just as it says, it has been implemented, and then it was studied how it went. We have also implemented this in Sweden now, and it's highly accepted. And it is our feeling that somewhere between like 25 to 40% of women actually opt to have an IUD inserted at the cesarean section if they receive good information. So this is really underused. And if you don't do it at your hospital, go home and start now. And the result then of the Scottish study was, as you see here, that a lot of women opted to have it inserted, not as many as in Sweden, though. There are few expulsions, not at all in the neighborhood of insertion after a vaginal delivery. And that is, of course, because the cervix is closed much more. So that's probably the reason. There were no cases of uterine perforations, and if you do perforate, of course, you will discover it because you have the uterus right there. One case of infection is probably what is expected, and follow-up rates in this study were high, and that's why we can also rely on the expulsion rate. We can think that it's probably true. And like it says here, close to 93% of respondents were fairly happy with the IUD insertion. I would also like to point out that there are good ways of increasing use of contraception after all kinds of pregnancies and also without pregnancy, and that is to use structured contraceptive counseling. This is the study that we performed, and in this study, we could actually show that we had fewer repeat unwanted pregnancies within 1 year in the abortion cohort in the study. So within 1 year, and you can just imagine then, if you extrapolate, thinking that women probably don't want to become pregnant for another maybe 15 years, you can imagine the impact that it will have on each individual in this study. So the questions again to be asked is, do you wish to become pregnant again? When would you like to become pregnant again? And how important is it for you to avoid pregnancy? How okay are you with a termination and an abortion? Of course, this speech now has been focused on LARC, and I think that is because all of us basically know how we handle short-acting reversible contraception after pregnancy, because we've done that a lot during all these years, and the knowledge gap is on LARCs. So that is why I've chosen to focus on this, but of course not everyone should have a LARC, and it's very important to remember that the only contraindication to start immediate contraception after pregnancy is if you give a combined hormonal contraception after birth. You should delay start to about 6 to 8 weeks postpartum when the VTE risk is lowered. And always think about choosing the right method for the right woman. And these questions that I've listed can help you do that. And then the take-home message is provide as soon as possible when it is reasonable and acceptable without side effects. Thank you so much.
Yeah, so Helena, thank you so much for this really interesting presentation and the data, which is really, really great. I think we learned a lot. And now it's my pleasure to introduce Johannes Bitzer, who's a senior professor, a well-known senior professor from the University Hospital in Basel. And he's gonna present and talk about contraception in the perimenopause. Johannes, the floor is yours. Johannes, you have to unmute.
Sorry.
Yeah, now we can hear you.
Now you can hear me. Okay.
Yes, yes, yes.
Yeah, I wanted to thank you that I'm invited to take part in this symposium with my colleagues. And I'm focusing now at another life phase, which is the contraception in the perimenopause. These are my conflicts of interest for this presentation. ESC supported by Bayer, but there is no influence on the content. So I believe we should always try to understand a little bit the life phase in which our patients are in. And the premenopausal or perimenopausal life phase is a very challenging life phase. There is, on the biomedical side, the decline in fertility, ovarian aging. There is an increase in miscarriage, chromosomal abnormalities, pregnancy complications. The progesterone decline and estrogen fluctuation lead to irregular heavy bleeding. I may already start producing climacteric symptoms, bone demineralization. There is an age-increased risk for cardiovascular diseases and an age-related increase for gynecological neoplasia. But as you know, I'm always trying to bring in the psychosocial aspects also. In this life phase, many women have this family planning ambivalence. Should I remain childless, late child, enough children? They have maybe adolescent children, and at the same time, they should care for parents. There is the professional career challenge at the maximum and decline in energy. We know about mental health issues, burnout and depression, and loss of sexual function or difficulties with sexual function. So what are the conditions? We have the age-related increase in high-risk pregnancy and fetal abnormalities. We have the age-related increase in cardiovascular diseases, cancer and osteoporosis. And we have the possible negative impact on quality of life, heavy bleeding, iron deficiency, climacteric symptoms, depression and sexual function. Now that means that we have to be aware that we are in a broader medical field. You know, there are studies showing this age-increased cardiovascular risk, which begins to rise in women during perimenopause. This is very true for those who get into early menopause. The incidence of VTE increases. The incidence rate of women for cardiovascular complications increases with age. Lifetime risk of cancer increases, except for cervical cancer. Breast, endometrial, ovarian cancer increase with age. Cervical decreases. About 80% of breast cancer cases are in women aged 50 or older. Ovarian cancer is much less common than breast cancer, but rate increase exponentially with age. And endometrial cancer is primarily a disease of old age, but can, of course, also occasionally affect younger women when we especially have genetic risk factors. As you all know, cervical cancer is you could say, the cancer of the young woman almost. Regarding sexual health, very famous studies from Lorraine Dennerstein that during this menopausal transition, there is an increase in sexual dysfunctions, there is lower libido, vaginal dyspareunia, partner problems. The bone is threatened in its stability. There are already these perimenopausal symptoms of vasomotor symptoms, hot flashes and sweats. Of course, the big issue of heavy menstrual bleeding, as you know, one of the frequent, let me say, reasons for consultation in gynecologists. What is also important and not so well known, that it is a time of increased risk for developing depression, in context very often with vasomotor symptoms. So if you look at that, what should contraception provide? It should prevent high-risk pregnancy. It should have no increase or possibly protection against the age-related increase in cardiovascular disease, cancers, osteoporosis, so no increase and maybe even protection. It should not aggravate or better alleviate the perimenopause-related negative impact on quality of life, heavy menstrual bleeding, iron deficiency, climacteric symptoms, depression, sexual dysfunction. So this is a little bit the context of contraception in more in general health. Now, I think when we look now to find the best method for the individual woman, you all know we have this contraceptive toolbox with hormonal, non-hormonal, short-acting, long-acting, patient, provider independent, etc. I think for all of us, it is really important that we get evidence-based information of these four big issues regarding each method. Its efficacy and effectiveness, you know, the typical use. its health risks, its side effects, which is tolerability, quality of life, and its possible health protection, and positive quality, positive impact, like the benefit. So these are the four main pillars, I would say, which we need to understand and communicate with the patients based on best evidence and on ongoing, maybe also new studies. Now, let's have a short look at, or not a short look, but let's have a look at what I call the big five for this age group. Copper IUD, LNG IUD, Implanon, DMPA, progesterone-only pill, and combined hormonal contraceptives. First, information, there is no contraindication by age only, which is, I think, important. And if you look now at these different methods with regard to these four basic elements, we can say that the copper IUD has a very high effectiveness. There is no cardiovascular risk, and the evidence-based level is always put behind. There is no cancer risk. There are rare complications related to the intervention, expulsion, perforation. There may be hypermenorrhea, dysmenorrhea, lower abdominal pain. But again, this frequency is rather low based on evidence level 2. What is important and what we frequently forget is that there is a protective effect, endometrial, even cervical and ovarian carcinoma. These are newer studies which make this method also from the prevention point of view quite interesting. An important point regarding the methods is that there is no protection against STI. Now you may say perimenopausal women don't need STI protection. This is wrong. Many studies show that, new partners, divorces, that the STI prevalence is not low in this age group. But one of the most important issues is that the copper IUD needs intervention. So it's not under the control of the woman. She has to go somewhere and get it inserted. LNG IUD, of course, the other form of intrauterine contraception, very high again, no cardiovascular risk, breast cancer risk conflicting, none or low. It disappears 10 years afterwards. There are these studies which seem to indicate that there might be a slightly increased risk. The complications of expulsions and perforations are already mentioned. Now, what about the tolerability? I mean, we have the bleeding irregularity, but we have amenorrhea, which may be considered as a side effect, but which also may be considered as a positive issue. Big issue, and Teresa was already mentioning it, progesterone-only contraception and mood. I think the answers are not yet clear. It's the same with progesterone-only contraception and sexual health. We're still ongoing in this field. Why is it so important? Because compared to other issues like irregular bleeding or like thromboembolic disease, which can be observed and studied in clinical trials, for these two issues, you need what we call subjectivity of the patient, which is either by interview or by questionnaires, meaning that you will have not the same level of preciseness as you have in the more physical fields. Endometrial carcinoma, protection also under tamoxifen, HMB, very important and very clear. Of course, no protection against STI, and again, it needs intervention. Now, the LNG IUD has one additional interesting aspect in this age group, and maybe we can discuss this at the end again, is about that it is a contraception that may lead into menopausal hormone therapy, leaving the IUD in, which quite a number of people do now, and in patients who already develop climacteric symptoms or at a later age, then adding transdermal estrogen. Implanon, you have heard about it, very high. Again, the issue of the safety, health risk very low. And if there are complications, it's more related to the intervention. Again, the issue of bleeding and mood. In some patients, I think we have to admit that there may be skin and weight problems very rarely. We don't know much about sexual health. We know about benefits like dysmenorrhea, ovulatory pain, maybe also endometriosis, menstrual migraine, and we also are aware there is no protection against STI, and it needs intervention, which make a difference to what I'm going to talk about now, which is the progesterone-only pill, which with this medium effectiveness due to the issues of typical use under the control of the woman, certainly regarding health risks, no health risks really. Again, like with other progesterone-only contraception, issues of probably bleeding, irregularity, mood, I think I could skip skin. I didn't see anything there. But again, you do have some profit, dysmenorrhea, ovulatory pain, endometriosis, menstrual migraine, which really can be a condition women suffer a lot about. Here again, it's no protection against STI, but you know, the issue of efficacy versus effectiveness, meaning user dependent, is in our view, of course, some sort of a negative characteristics. For the user, it may be a positive characteristic because it's under my control. I think frequently we underestimate why there is still a rather high rate of women using the pill because it's under their control. Depo-Provera, I think it was already mentioned that I wouldn't say that this is a good method for this age group with all the issues of bone health, even with you know, the classical risks regarding VT and cervical cancer. There are some controversies. There is, of course, the big issue that you may even increase risk of HIV infection. Certainly no protection, maybe even increase of HIV infection. You have again the bleeding problems, you have the weight gain problems, you have the mood swings. The fact that you have a longer period of getting pregnant after stopping is maybe not such an important argument in this age group. Now here we are with the combined hormonal contraceptives. Well, a long list, so to say, of possible risks, although, and Teresa has already mentioned it, of course, the risk in absolute numbers is not very high, but relative risk increases get more important with increasing age. But still, looking at the important part of risk counseling, we could really make these 1,000 women and then really indicate how many of them profit and how many of them have risks. You all know the broad spectrum of possible tolerability problems. But interesting enough, and I think this brings me to the point of individual counseling, you have a long list of possible positive effects. Protection against cancer, ovarian, endometrium, colorectal, osteoporosis prevention in this age group, climacteric symptoms treated, reduction of heavy menstrual bleeding, reduction of hyperandrogenic skin symptoms, which frequently may occur in this age group due to some imbalance between estrogen and testosterone, mood improvement, which psychiatrists have seen that this treatment may even improve patients suffering from major depression, improvement of sexual function, which was also shown. So it is this is a tool that is that has very different perspectives in this age group. Again, no protection against STI, but again, the issue that is under the control of the woman. Here again, we have, like with the LNG IUD, we have this possibility, but we need a lot of more studies that you can go from contraception to menopausal transition, to menopausal hormone therapy, with the new preparations with estradiol. And this is already done by quite a number of patients who prescribe still or encourage women who had never any cardiovascular problem during many years to continue with their estradiol containing pill. But this is something which, of course, needs much more studies. So Helena was just already mentioning it. It's contraception counseling is also an art. It is a lot of science. We need a lot of good studies, but it's basically in the consultation we have to bring sort of three variables together, which is the method profile, which I was describing. It's the woman's profile, middle age or perimenopause, and it's the context. The social cultural context, which makes, of course, huge differences in the two variables of woman and context. So basically, it's this sort of art of finding the best fit between the woman with her expectations, her concerns, her beliefs, her values, her medical profile with her risk, medical history, symptoms, with her psychosocial profile, the stresses she lives in, the mood, sexuality, and, the methods, combined hormonal, progesterone only, LNG, implanon, copper, barrier methods, and natural family planning methods or fertility awareness-based methods, which in this age group, well, I'm not mentioning it, but we might discuss it maybe if there are questions. We have tried to describe this sort of finding the right method for the right woman with a so-called three-step approach. I think in a first step, we should really listen and understand the needs of the woman. What does she really want? What does she not want? What are her conditions, her needs, her expectations, and her knowledge or her previous experiences? And with this already, we may exclude some methods she does not want. At least we can exclude it preliminary. Like, for example, a woman says, I don't want any hormones. Okay, you would maybe put it aside for a moment, but maybe you could come back later in the decision-making process. So here you already exclude some methods. For example, if there is a need for a very effective method that in a very distressed patient, you would certainly have a tendency to go for LARCs or exclude fertility-based methods. The second step we usually do in the consultation is you look at the medical profile, and here you use the MEC so that you would exclude the methods which the woman must not use. Now, in this age group, of course, due to the age-related issues, the MECs get broader. You may have to include, because very often these women have comorbidities like obesity, like maybe also beginning diabetes, like hypertension, etc. And that is an important part of your workup, to look in the medical profile and to look how this would make a decision excluding certain methods for this woman. So the first two steps somehow are not are negative, are exclusion steps. And then there are methods left. And then you can use your knowledge about tolerability and benefit to see whether, with a medical or also psychosocial profile, you may find a method that even improves quality of life and that fits to the individual needs. All about these issues. Risk of osteoporosis, anemia, PCO, family risk of ovarian carcinoma, the issue of ease of use, facilitate compliance, enhance the effectiveness. Then the rather, I would say, advanced knowledge which you need to, if you choose hormonal contraceptives, which type of estrogen do you use, which dosage, which type of LNG, the big division between androgenic and non-androgenic, which I think are different balances where frequently you have, for example, effects on the skin versus effects on sexuality and effects on mood, etc. So this is this part where you bring in your clinical experience and your knowledge. So my take-home messages are: perimenopausal women have a naturally low fertility rate, but still if we need effective contraception to protect them against unwanted high-risk pregnancies. The transition period to menopause carries with it age and endocrine-related changes, which have an important impact on the general and reproductive health of the woman, as well as her quality of life. Each contraceptive method has 4 basic characteristics with special relation to the perimenopause: efficacy, effectiveness, health risk, tolerability, and health benefits or quality of life. Each perimenopausal woman has her individual psychosocial profile, consisting also of her individual objectives, her values, her medical risks and resources, and her psychosocial profile. Good contraceptive counseling and care aims to make the best fit between the contraceptive method and the individual woman by structured counseling, which maybe you have your own way, but it's basically like a little bit a 3-step approach, which is based on patient-centered communication and shared decision-making. Thank you very much. And I finish here and I give my, sorry.
Thank you, Johannes. As always, very informative.
Thank you.
Yes, lovely. Okay, so with that, thank you. And we will now go to the questions and answers part of this webinar. And we have received quite a few questions. And I think we decided that each and everyone do their own questions. So Teresa, would you perhaps like to start with those that were posed for you?
Yes. During at the end of my presentation, I have already write some answers. I'm sorry for that because the question disappeared from the chat. But the main of the main questions were regarding the bone mineral density, regarding the use of Depo-Provera and the safety in the group of adolescents. It's completely safe because there's no risk of fracture. When we say there's a decrease in bone density, decrease is in between the physiological intervals. So there's no risk of fracture unless there are adolescents with some disease like
Anorexia.
Yes, corticotropy, anorexia, post-chemotherapy. Otherwise, it's quite safe to use Depo-Provera. And it's true for adolescent and it's true for the older woman or for the adult woman. When we say that it's a decrease in bone density, it's a decrease in the studies. is not a decrease that have an impact in real life or daily life of the adolescents. So we have to be careful in athletics adolescents or very young adolescents that are they are very active in sportive, like some arctics, but the majority of for the young people are quite safe. The second question is regarding, that is already here in the chat and I didn't answer, is the difference between if adolescents are eligible for intrauterine device with higher doses. If you want to have contraception and to treat heavy menstrual bleeding, you can insert an intrauterine device with 52 in adolescent. It's not so painful. And now we have a local anesthetic if he's need. But in my experience, they are eligible for that, and the quality of life will be optimized. And another question is, so I don't think I have any more questions. Oh, the other question is, after the first menstruation, what are the number of the years or the number of months that we will wait after the first menstruation to start a hormonal contraception method? So we don't have a period of time, but if the adolescents are in risk of unplanned pregnancy, after the first menstruation, we can start hormonal method. It's quite safe.
Lovely. Does that mean that it's my turn now? Maybe.
Yes, it is.
Yes, it is. Let me see. So how and when to start oral contraception after medical abortion? After medical abortion, the consensus is to start either on the same day as you take misoprostol or latest the day after. So never wait until the next menstruation, as there is always an ovulation preceding the next menstruation. And a lot of women ovulate already within like 8 to 12 days. So always start latest the day after misoprostol, and that is irrespective of the gestational length at abortion. Can you comment on the effect of immediate postpartum IUD placement on the ability to visualize strings at the time of IUD removal? This is a good question. I don't think anybody really knows. If you look at vaginal placement postpartum, even when you insert the IUD, you can still see the strings. And so then it's important not to shorten the strings before you insert it, because then they can curl up. So don't shorten the strings. And then, excuse me. What we advise women to do is to have a rather soon follow-up visit, like within a week or two, and then to sort of shorten the strings if needed. At the time of cesarean section, it is possible to shorten the strings before you insert it, but in my hospital, we stopped doing it. Instead, we also tell women to go for a soon follow-up visit, and then to have the threads, cut a little bit if needed. Sometimes, women have an ultrasound for some reason with some gynecologist out there who is not so familiar with this. And then they can see that the threads are like curled up inside the uterine cavity. And they're like, oh, this needs to be like fixed or whatever. No, it doesn't need to be fixed. The threads can be there. It doesn't cause any harm. If anything, it might add to the contraceptive effect. And the problem is with strings that are not visible at the time of removal. Exactly how common this is basically unknown. Most of the time, the threads are in the cervix and can be removed with like a forceps or with a Cyto brush or something like that, and you can just get the threads. I mean, remember, these are women who have had children. Yes. Let me see now. What was the next one? Suddenly everything just moved here. Visualize strings. For nulliparous women, is there good evidence to use the 19.5 milligram levonorgestrel IUD versus the 52 milligram levonorgestrel IUD? Yes, there is good evidence. Both are highly acceptable to women, but the 52 milligram IUD has advantages, especially in young women, I feel, who want to postpone childbirth for many years to come, where the 52 milligram device can now be used for 8 years and the other one can only be used for 5. I know a lot of people feel that perhaps the Helena, the 19.5 milligram device, will also get a prolonged use, but it won't, because the capsule is different. So basically after 5 years, the capsule has ended. So it won't be prolonged like until 8 years, just like the 52 milligram. Also, the 52 milligram device has a more favorable bleeding pattern, you might say, with less irregular bleeding and a higher rate of amenorrhea, if that is what women want. So those are the difference, but they are both highly acceptable methods and can be used in nulliparous women. Doesn't matter. Yeah, that was with that. And then it's perimenopause. That's you, Johannes.
Yeah. What was the question?
Depo over 50 years of age contraindicated due to fracture risk. I think that might be the question, but it's a little bit like short-handed.
Yeah, well, I wouldn't give Depo-Provera to a 50-year-old woman. I mean, there is no real reason to do that. You would have a possible negative effect on the bone immediately and really increase fracture risk. You would even deteriorate the lack of estrogen, etc. So I don't think that would not be a method I would choose. Mm.
It's definitely not a first-hand choice anyway.
Yeah. If you don't have anything else, but usually, yeah, there are other options. Mm.
So what about drospirenone, progestin-only pills in perimenopause?
Yeah, that's an interesting issue. You know that, of course, you have the big advantage that you don't have any cardiovascular risk. You don't, from the risk profile, it's very good, and it can be taken also by women with additional cardiovascular risk. The issue is really about tolerability. We do not have very good studies in this age group whether this drospirenone ovulation inhibiting dosage causes problems, and I'm coming back a little bit to this issue of mood and sexuality, whether there might be negative effects regarding those women who really suffer from estrogen, lack of estrogen somehow on their brain and their body. So, but I think it would really be necessary to do studies. So maybe Philipp and you two ladies, you could put up a study looking into especially this age group where, from the risk profile, it's of course very good. Yeah.
Yeah, I think in the registration studies and the phase 3 studies, they included women up to 50 years of age, of course, because it's a progesterone only pill. But I don't know if they have done any sub-analysis on that.
Yeah.
So they're very seldom sub-analyses performed. So this is the really interesting question for you, Johannes. Is it possible to use menopausal hormone therapy as contraception I think it should say in perimenopausal women?
This is a great question.
Yeah, well, look, if you take the estradiol or even the estetrol containing pill, you have already sort of a menopause preparation with the additional benefit of protecting you against pregnancy. So I would not go for another, very frequently, of course, recommendation is you give transdermal and you add dufaston for 10 to 12 days, etc., that doesn't give you any protection against pregnancy. It's a menopausal. This I would not do before, well, you know, so to say, the official age would be 55.
But I think, Johannes, the question is really, is the progestin dose in menopausal hormone therapy enough to act as a contraceptive in perimenopausal women?
No, if it is, if you understand the classical menopausal therapy, the transdermal estrogen with a oral or the patch or whatever, this is not. You cannot use that for contraception.
No, it's not. It's not enough. The progestin dose is too low.
Exactly.
To be used as a contraceptive in a woman who is ovulating.
Exactly.
Right?
Exactly.
Yeah.
Especially
so I think that's the answer. The answer is no, really.
Irregular ovulation, you know, then you get into real trouble.
And then it says something that I can't understand. So NFP in climacteric with special rules an option. I cannot understand that question, so I will skip that one. And if this anonymous participant would like to clarify that question, I would love that. Then I think it's a question for me. For PPIUD in breastfeeding women, should we delay insertion to interval insertion? And I think that is not at all what I wanted to say with that slide, that there's an increased risk of perforation. What I really wanted to point out is that these women should have an IUD inserted by an experienced provider. This is not something like, oh, I've inserted 10 IUDs, now I go for the breastfeeding women. That is a bad idea. Because it's all about the feeling in your hand and like really being able to feel the fundus and know when you're there and having this gentle and secure hand and being able to interpret the signals from the sounding and the IUD. So that was my point. And no, we should absolutely not delay it. If we do, we put the women at risk of unintended pregnancy, because as you know, preceding the first menstruation comes an ovulation. And then women usually come at the first menstruation and then it's too late. Yes. My question, yes, for perimenopause. Can you use natural family planning? That was what NFP stood for in perimenopause. Johannes.
Well, not really. Not really, because as you all know, natural family or fertility awareness-based methods are based on the principle that you predict the fertile window. And you predict the fertile window by an algorithm which summarizes the previous cycles. So you go back for based on really regular cycles. And you integrate that, and from that you can, you know, count the 7 days of the fertile window. In the perimenopausal women with irregular cycles, you don't have this basic information. I mean, it's people have to understand that fertility-based methods are predictive methods based on previous cycles.
Oh. Thank you so much, Johannes. So that, I think, concludes this webinar, and thank you all for attending. I think we will put on the final slide here as a thank you to you all for celebrating World Contraception Day with us. It has been a pleasure, and please stay alert and vigilant and fight for women's rights out there and talk well about contraception, because it does benefit us all and our world for sustainability. So with that, I would like to thank all our speakers. I would like to thank Orgamed, but I would also like to extend my very thoughtful thanks to Bayer for sponsoring this webinar. And thank you for all that you do developing contraceptives with high acceptability for women. So thank you all and have a very nice evening.